Das für dich? Ja. So welcome back. I wish to welcome you all for the second session. Now we want to have some outside views. There is much more going on here in Munich and Bavaria than just DigiMed, fortunately. And one of the most prominent researchers and clinicians in the field of cardiology here in Munich is Professor Steffen Marsberg, who is heading the cardiology department of the Klinikum Großhadern and the Innenstadt campus. So a huge department, but also really very prominent and internationally visible scientists. And we are very much looking forward to your talk on digital approaches to optimize patient care. Steffen.
Thank you, Harry, also for the kind invitation, also Moritz, and congratulations on the successes of DigiMed Bayern, which is, I think, a very impressive achievement. So I will give you sort of a user's perspective on digital medicine or digital health in cardiovascular patient care. I'm not an expert in digital medicine, but in general, I think that cardiovascular diseases are inherently suited, optimally suited actually, for digital applications, because we have well-defined disease phenotypes, we have large cohorts and data sets, because the diseases that we treat are very, very frequent. We have hard and very well standardized clinical outcome measures. We have well-established evidence-based treatment paths. On the other hand, we have access to liquid and tissue biosamples. We have a lot of imaging and also digital ECG data, for example. We have telemedical applications and also wearable devices that we can use. And there's a huge area of animal research that we can use animal models to reverse translate our findings that we obtain in patients. So what I want to do is I will give you my perspective, my personal perspective on where I see emerging areas of digital approaches in cardiovascular health. Of course, it's my personal perspective, and I'm not presenting everything that is relevant. And I will, first of all, I think one area that is really emerging, and most of you are aware of that, is that the area of multi-omics approaches, which require, on the one hand side, of course, advanced omics technologies, but also, of course, digital and combined with bioinformatic expertises. And one area that we are interested a lot is the area of thrombotic cardiovascular diseases, which are venous thrombosis, myocardial infarction, and stroke. And these disease entities share a common joint pathophysiology, which is the collaboration of not only platelets and coagulation to drive the thrombus, but also the input of immune cells, which join forces to induce thrombus and to induce thrombogenesis and clot formation. And this collaboration, which is called thromboinflammation, has turned out to be a major mechanism of most of the thrombotic events that are complicating cardiovascular diseases. And coming from basic research, we wanted to see whether these basic mechanisms also are relevant in human settings. And to test that, we developed a use case of patients with acute and chronic coronary syndrome. So we looked at patients that presented to our hospital with chest pain, and we tried we tested as to whether or not we can use the signatures of thromboinflammation to discriminate between patients that have acute versus chronic coronary syndromes. And what we did is we collected samples, actually multi-layered type of information from the patient in addition to the clinical data sets. So we did single-cell RNA sequencing, flow cytometry, but also we did plasma proteomics and prime sequencing. And all these different layers of information were put into a multifactorial data integration analysis to come up with sort of groups of parameters that show the greatest variance between the different patients enrolled into the trial. And when we did this, we came up with different factors, so combinations of parameters identified in this multi-layered analysis that were mostly predictive of the clinical values, meaning we're able to predict chronic coronary symptoms and discriminate chronic coronary symptoms from acute coronary symptoms. And one example is factor 2. And when we looked at the contributions of this factor 2, or the subsets of parameters that were included, these were mostly inflammatory parameters. And actually, if you look at factor 2 in greater detail, you can actually see that in contrast to non-CCS patients, so patients without coronary disease, but also with patients with stable coronary disease. In patients with acute coronary syndrome, this factor showed shifts that were also time-dependent. So very early on, after presentation in the acute setting of acute coronary syndromes, there was an increase in these factors, which vanished over time and then came back to a level that is similar to the chronic situation. And we think that these parameters, of course, at this stage, this is not applicable to point-of-care testing, but what we do envision is that we could use these types of tests. We have to optimize them, of course, as point-of-care tests, and then we could, these tests could sort of provide important additional information in addition to the clinical data in order to do a risk stratification of patients that present with acute chest pain. And this is something we are currently testing in the multi-base LMU Predict project. Another use case that I want to briefly touch with you is the use case of acute embolic stroke. So we have patients that present with embolic stroke, but not every embolic stroke is same, because the pathologies, of course, differ in particular in terms of the origin of the thrombus. So we have two very frequent causes, which is atrial cardiopathy and atrial fibrillation, where the thrombus develops here in the left atrial appendix, as opposed to the classical atherosclerotic plaque rupture, where the thrombus is developing in an artery under high shear stress and then embolizes into the brain. This is important because the origin of the thrombus also drives our antithrombotic management. So in atherosclerotic disease, it's mostly based on antiplatelet therapy, whereas in the context of atrial fibrillation, for example, the treatment of choice is oral anticoagulation. So can we use phenotyping of thrombi that are collected nowadays through our neuroradiologists to discriminate the origin of the thromb? And I think we can. So what we did in a recent study together with the colleagues of the neurology department, neuroradiology, difficult word, we collected the thrombi and analyzed the thrombi using single-cell RNA sequencing and site sequencing in combination with FACS sorting and prime sequencing, and we analyzed the composition of these thrombi. And actually what we found in this thrombi is not only platelets, so the classical players of thrombosis, but a lot of immune cells. And these immune cells were actually very different from the immune cells that we find in blood. So there is a specific recruitment of inflammatory cells in the thrombus at the site of development eventually, that then defines the immune landscape of these thrombi. And we can use these thrombi these immune landscapes to actually define the origin of these thrombi, because we find a substantial difference in the immune landscape when we compare low shear stress thrombosis compared to high shear stress thrombosis. So patients where the origin was defined in this subset were used to discriminate between thrombi that developed in atrial fibrillation compared to atherosclerotic-induced thrombosis, and you see that the landscape between these thrombi is substantially different, as indicated by the blue and the red color. Next, of course, digital approaches will help us to reach the goal of precision medicine, and Harry has already alluded to this, and I will give you a couple of other examples where I think this is important. One major advance, which I think will be important in future, is the interpretation of ECG signals beyond the classical interpretation. So if you analyze huge amounts of ECGs from one patient or long ECG recordings of one patient, and superimpose these signals, you can actually get additional information which is beyond what we typically interpret from ECG recordings. And this is, we can get an impression of the autonomic function of the individual patient. And we can access both the deceleration capacity, which is a measure of vagal tone, but also periodic repolarization dynamics, which more or less assess the sympathetic effect on repolarization. And both of these parameters are very important for risk prediction and can be used to analyze treatment responses. One example is shown here. It's an old study by Axel Bauer. He showed that actually defects in the vagal tone, as assessed by low deceleration capacities, is associated with a substantially increased mortality, and this was independent of the left ventricular ejection fraction. We will use this autonomic function assessment in an ongoing study, which is called a Delphi trial, in order to triage patients that present to our hospital into the emergency room in our hospital with chest pain, in order to decide whether these patients have to go directly to cath lab or can be discharged and re-evaluated on an outpatient basis. But already another aspect of why autonomic signaling evaluation can be interesting is illustrated here. We have patients that, according to guidelines, currently receive ICD therapy. And these are the patients that have reduced ejection fraction. Typically, indication for ICD implantation is made when patients have ischemic cardiomyopathy with an ejection fraction below 35%. And if you analyze in this patient group the sympathetic dysfunction, you can actually see that if there's a substantial degree of dysfunction, the profit from ICD therapy is enhanced. This may not be so important in the context of ischemic cardiomyopathy, but it can be actually a very important decision-making information in the setting of non-ischemic cardiomyopathy, as shown here in the Danish randomized control trial. In this subset of patients, it is known that not all patients actually profit from ICD therapy. And when you apply to the subset measures of autonomic dysfunction, you can actually see that patients that have a normal autonomic function, as shown here by low levels of periodic repolarization dynamics, do not profit from ICD therapy, whereas at a cutoff here of around 7 PRD, there is increasing profit from ICD therapy. And of course, future studies will have to test whether really tailored therapy driven by assessment of autonomic function can help decision making. AI-powered interpretation of data sets that we obtain from our patients can also help in our, can support our decision making. I will show you some examples that have been published recently. One example uses AI-powered interpretation of ECGs to detect acute coronary occlusions in 12 lead ECG recordings. And what this group did was a retrospective analysis of ECGs, applying a previously developed AI approach to interpret ECG recordings, and in order to detect whether or not in this patient a vessel is occluded and requires emergent revascularization. So that was the primary endpoint. And actually, AI-powered ECG elevation was better than applying the classical guideline-recommended STEMI criteria, so ST elevation criteria, and was as good but faster as interpretation by an ECG expert. So this was retrospective data, but there are also now increasing numbers of randomized trials. This is a randomized trial, and actually where not patients were randomized, but echoes, also cardiac ultrasounds. And this randomization was done into standard evaluation by a sonographer. Sorry. sonographer as an initial assessment and then repeat assessment by a cardiologist, compared to AE-based assessment and then subsequent assessment by a cardiologist. And you see that the AI was not only non-inferior, but actually was superior to sonographer initial assessment, and actually was substantially faster. So AI-based approaches will, I guess, at least for at least some parameters of echoes, be important in order to make the process of evaluation more efficient in future. And the last example is a very recent example where, which was actually conducted in Nigeria, where patients, so women that were pregnant or postpartum, were randomized for screening for peripartum cardiomyopathies, which is actually very frequent in Nigeria and one of the major regions of perinatal death. And the study randomized patients to standard of care as opposed to AI-powered digital stethoscope analysis combined with AI-powered ECG recordings. And what the study showed that this approach, so the intervention, the AI-powered intervention, was superior in detecting reduced ejection fraction in this cohort of patients compared to the established standard of care. So these, I think, are some examples that are showing what is the potential of the digital approaches for future medicine in cardiovascular context. We have touched and heard this in the previous talks that, of course, we need contemporary platforms that allow federated learning and use similar languages in order to be able to exchange data. This is something that we are currently looking at in a cohort called FLOTO, where we try to implement federated learning to predict TAVI outcomes, which is funded by the DZK. I will not go into detail in this study. Next generation wearables, I have touched this in the beginning, are one advantage that we have in cardiology, maybe compared to oncology, which allow continuous telemonitoring and require data integration at healthcare platforms. And there are a number of wearables available in cardiovascular medicine. I will show you two examples that use these wearables in studies from our hospital. One study used implantable wearables, so the event recorders, in order to detect arrhythmias, severe arrhythmias, meaning AV blocks, severe AV blocks, ventricular tachycardias, atrial fibrillation or ventricular fibrillation in patients post-MI. And in fact, maybe as expected, but the difference was very substantial. Telemonitoring significantly increased the detection, the ability to detect these arrhythmias, which were actually associated with adverse outcomes. So this is one approach. Maybe it's a more invasive approach. Another approach that we tested is the digital screening for atrial fibrillation using smartphone applications. And this was done in collaboration with the Versicherungskammer Bayern, where we enrolled more than 5,000 patients, and they were guided to use their smartphone to screen for atrial fibrillation compared to no smartphone-based application. And in fact, as you see here, smartphone-based AF screening substantially increased detection of atrial fibrillation in this cohort of 5,000 patients. So digital screening using smartphones provides substantial benefits for detecting atrial fibrillation in healthy probands. This is one of the messages of this study, but another, I think, even more important message of this trial was that it's actually a novel, siteless, pragmatic, digital app-based study. So patients were informed about the trial via an app. They were consenting into the trial, into participating in the trial via an app, and they were guided through the trial and also through the measurements through an app-based approach. So we never saw any of these 6,000 or more than 5,000 patients in the study. And I think this brings us to another very interesting application of digital approaches, namely the support of our trial units in conducting virtual trials and also in supporting eventually the recruitment. And of course, digital approaches can support many steps in the context of planning and conducting clinical trials. And one aspect that I think could be very interesting is the support of recruitment. And this is something we have implemented at our hospital, where all patients are the patient data are collected in a structural manner and are sort of back-upped or tested against the clinical studies that are ongoing on our trial. And there's an alert for any patient that whether or not this patient is suitable for involvement in any of the ongoing trials. So with that, I would like to summarize that I think we are in a very good position in order to apply digital solutions. So far, I think in cardiovascular medicine, it's not really implemented, at least not in a broad sense. So there's room for improvement, but I think we are on a good way. And in a longer run, I think implementation of digital approaches will help to optimize the care of cardiovascular patients. Thank you.
Stefan, that was very impressive. Also, the multifaceted approach. I mean, the many things that can be done with these AI-based methods. So the talk is open for discussion now. So I would like to get started, Stefan. You showed that the neutrophils inside the embolus are different from the circulating neutrophils, which I think is really interesting. Is there the opportunity or the chance that the neutrophils change their expression pattern once they are embedded in a thrombus? So they are, I mean, the same who go in, but not the same once they are, I mean, in this environment.
This is a very good question. Actually, for a long time, it was considered that neutrophils have a program that they get when they are born, and which is sort of continuous until they die. But this turns out to be wrong. So actually, they have a quite dynamic ability to adjust to environment. And that is actually what we think is happening, that depending on the local environment, including the presence of platelets, of the activation status of platelets, but also of other things like shear stress, so physical aspects, have an impact on the program of neutrophils. So they are very plastic, more plastic than we originally considered them to be.
Other questions?
What is your vision? How long will it take to include clinical decision support in routine care, like real-time use of? So the question is, how long do you envision it takes to implement clinical decision support in clinical or daily clinical?
So I think it depends very much on what the parameter is that you will use. I think it's a long way to go if you want to use omics approaches. There are point of care omics that are already available, but still we are talking about point of care tests that take still at least an hour for first data sets available. It's probably not so much of a long-term perspective if you look at other data. So what I showed you in the Delphi trial, we use short ECG recordings that are from which we can, based on AI-powered approaches, extrapolate autonomic function assessment. And this we can already do. We validated that in a huge cohort, and now we will test whether these short-term ECG lead the triggered or assessment of autonomic function can guide decision making in patients. So this is, I think, something that should be more readily available.
Because it's impressive work, and the question is, when does the patient profit from it? So
great
Yeah.
work.
So one study that would be interesting, but it's very difficult to do, is to use the autonomic parameters for decision making as to whether or not ICT implantation should be done. And the major reason is that there are other studies ongoing that are competing for the same patients. That's one aspect, and the other aspect is, of course, there's also economic aspect that make studies like this in terms of feasibility very difficult.
Thank you. Could you tell us something about why Nairobian women have more perinatal cardiomyopathies?
They probably do not have more, but it's less frequently detected at a stage where it's still treatable. Mostly because there's a shortcoming of physicians, so it's not the distribution of physician is very centered. So there are large areas where there is no physician available that is able to do a reliable echocardiography, for example, for early detection of LV dysfunction. So what they did is they distributed AI-powered stethoscopes to a large area in Nigeria. I think it was 6 larger areas in Nigeria that were independent of physician interpretation. Once the stethoscope identified a potential risk of having a cardiomyopathy, these patients were then sent for confirmatory ultrasound in a larger center.
So thank you very much. I guess there will be many more questions. I have a few, but we have to continue with the program. The next speaker will be Dr. Mike Mendelson, coming from Novartis. So translation is a key issue, also in digital medicine, AI-based medicine, and we are very much looking forward to your perspective coming from an innovative pharmaceutical company. Mike.
Great, thank you very much. My name is Mike Mendelson. I'm one of the cardiologists in translational medicine. At Novartis, translational medicine runs the early phase clinical program, so the first in human and the first in patient populations. So I want to thank the organizers for the opportunity to discuss pharmaceutical industry perspective on sort of how we translate the big data into actually new and better therapies for patients. So, I mean, as this group is very well aware, there's immense data sets on genomics and cardiovascular health outcomes, and this continues to grow. I think what was really highlighted nicely in this recent review is one of the new aspects one of the aspects that's really appealing on some of these cohorts is sort of the ability not to just take a passive approach, but to recall patients based on their genotype. And so I think while we're growing this amounts of health data, the ability to actually intervene is sort of growing and improving. In addition to sort of public and academic data sets, this has also been of interest to pharmaceutical companies. So within Novartis, many of the trials often have optional genetics consent, where patients can opt in to having their genetic health data being studied more on a broad scale to better understand their disease and develop better therapeutics. And Novartis, for example, has done a lot of sequencing and proteomics and multi-omics on many of the trials in which you can go back and study in a broader sense, even beyond just a single trial. So I actually specifically want to focus on one utility and one application. As this image from one of Dr. Shunkert's papers nicely show, there's many potential applications of genomics into cardiovascular health in terms of discovering new therapeutic targets. But I actually want to talk more about how we use it for patient selection, especially in a cardiovascular clinical approach. These approaches have really been proposed as transformative approaches, but the utilization of clinical genetic biomarkers has been quite limited in cardiovascular care. This recent review looked at what has been on the health authority labels for about 200 cardiovascular medications, and most of the genomics-based testing for cardiovascular therapies really revolves around CYP metabolism testing, and very much not as much on using genomics to better identify the right patient for your drug. There is some, as many of you know these medications, there is some genetic testing for familial hypercholesterolemia, but in general, there's very little genomic-based care. So one area you heard about earlier is about polygenic risk score. This has been an area of substantial research activity. Many common variants that attribute a small increased risk of risk. You can add them up and have a distribution in the population. There's very much a growing public awareness. There was New York Times articles highlighting this, and it performs very well at discrimination of patients in terms of various risk factors compared to other classic risk factors. However, the utility has been limited, and I think this evidence gaps needs to be really addressed with prospective clinical trials. And polygenic risk scores, I think, have gone through an evolution in terms of cardiovascular clinical trials. For me, the first generation of the use of PRS in clinical trials has really been on post hoc subgroups. We ran a trial, we go back and we say, how did people perform based on their distribution in terms of the polygenic risk score. There's many examples of this. One of them was in the Novartis-sponsored CANTOS trial. CANTOS tested canakinumab, an IL-1 beta monoclonal antibody, in about 10,000 people to prevent fatal and non-fatal heart attacks and stroke. And what they showed, published a couple of years ago now, is that patients at higher polygenic risk had higher event rates of MACE in the clinical trial. And though it wasn't statistically significant, there was suggestion that there was a higher clinical benefit with canakinumab at the higher polygenic risk score. Overall, the trial showed about a 15% relative risk reduction in MACE, but in the highest tertile, top third of polygenic risk, there was a 25% relative risk reduction of MACE. I think the second generation of polygenic risk score in cardiovascular trials has sort of been testing the return of the results of the polygenic risk score and looking how that has improved outcomes. Often this is just on surrogate outcomes, for example, in LDL cholesterol lowering. And while many of these trials have shown some benefit, much of it can probably be attributed to changing physician prescriber behavior. So the risks are returned, but then the patient provider is more likely to prescribe more aggressive medications in those patients. And I think the third generation of PRS that we're just starting to see emerge now, there's a few trials, is using a prospective polygenic risk score guided approach, but with well-established medicines that are already being used. And so what I propose is there a fourth generation where we develop new drugs that are focused on specific populations? And so using, just to continue on with that example of CANTOS and continue on in a cardioimmunology setting, we looked at polygenic risk scores in terms of, is this something we should pursue in terms of developing new therapeutics? So there was a few metrics that we thought were important. First of all, is this showing a higher cardiovascular risk in terms of the populations we're interested, and is this robustly seen in many external populations? And polygenic risk scores have been shown quite robustly to help discriminate risk. For cardioimmunology therapies, do you get a greater benefit? Potentially, yes. Has this been externally validated in any way? And currently there hasn't been any external validation. Can we understand the mechanistic link of why someone would respond better? You know, for polygenic risk score, about a third of them are probably linked, about a third of the variants are probably linked to known risk factors, a third probably linked to known mechanisms like cell adhesion, and a third completely not understood. So it's not clear why someone would get greater benefit from therapy if they were at a higher polygenic risk. And then what is the potential size of the population? Many of these cuts are quite arbitrary, the top 10%, the top third. How do you define what the threshold is for someone to get a medication or not, and the risks of a medication? And so these thresholds become quite important, and this is not quite clear with polygenic risk scores. And then the utility to guide treatment across different race ethnicities is severely limited, and so it brings a prospect of providing better care in some ethnic backgrounds versus others, and the current adoption of testing has been quite limited. So we wanted to say, is there a better approach? Can we use a different approach? And so one area that you've heard about is this somatic mosaicism, where you're not born with a mutation, but you acquire mutations in your cells and tissues as you get older. The US NIH has put a couple $100 million to better understand this phenomenon, so I think we're going to hear more and more over the next few years. But this has been implicated in many chronic diseases. One area for cardiovascular disease is the somatic mutations in your blood cell progenitor cells. These clonal hematopoiesis of indeterminate potential. These mutations give the cell some sort of survival advantage, and they proliferate. There's risk factors for increasing CHIP, like aging, environmental triggers like smoking, and that many of them are in these epigenetic regulator genes that modify the genome regulatory mechanisms. So at the very extreme, when you have many of these mutations in your blood cell line, they can be related to blood cell cancers, but it's become shown much more early on that this is a phenomenon that increased your risk for cardiovascular disease, likely of a magnitude similar of other established risk factors. The prevalence of CHIP is about 15% at 75 years of age, and this constantly emerges more and more evidence that there might be selected populations where this is even higher. For example, in a cath lab population, it was about 1 in 5, 20%. In more of an acute cardiogenic shock population, about 30%. And the absolute burden could potentially increase as the demographic shifts of a more aging population. This CHIP is sort of promoted by inflammatory mechanisms, and it itself is pro-inflammatory, and then it's sort of a self-reinforcing process. And because of its link to inflammatory mechanisms, it was studied in terms of whether in the CANTOS trial, which targeted immunomodulatory therapy, was there any difference in therapeutic benefit. So in the CANTOS trial, it was also shown that patients with CHIP had a greater risk for cardiovascular disease events, about a 30% higher risk. I won't go too much in mutation specific, but there are certain mutations, TET2 and DMD3, that were at even greater risk. And what they showed is that overall in this genetic biomarker subset, there was about a 7% overall benefit with therapy, about double 20% in the CHIP positive, and then specifically in the TET2 CHIP, about a 60% relative risk reduction of therapy. So if, we go and we say, is there any other evidence to support that there might be benefit? So this has been shown with multiple orthogonal lines of evidence through experimental models in animals, in Mendelian randomization, so studying studying variation in human population cohorts, and then in post-hoc clinical trials, that there's multiple lines of evidence to support that there should be greater benefit with immunomodulatory therapies in patients with CHIP. So if we look at those same metrics and compare sort of CHIP versus polygenic risk score, there is some potential additional advantages. There is a mechanistic link to a greater response. There is some external validation of this benefit above and beyond sort of retrospective post-hoc subgroups. The potential size of the population is a little bit unclear. There's a lot of complexities and nuances in terms of how you diagnose or identify CHIP, and this likely is true across all different race and ethnic backgrounds, although the current adoption of testing is quite limited in clinical care. So one of our focuses has been, how can we do better than CANTOS? So CANTOS tested canakinumab, focusing on IL-1 beta. So we said, can we take this IL-1 beta therapeutic and target pathways we know and add additional cardiovascular relevant pathways? So one is a bispecific antibody, MAS825, that targets not only IL-1 beta, but also IL-18. And the other approach we took is said, what if we go upstream to the NLRP inflammasome that activates both of these cytokines, but in a very specific way that allows the other inflammasomes to still respond to infections, but we just target the inflammasome that has been more implicated in cardiovascular disease and test it with an oral daily low molecular weight inhibitor. And so what we've been doing is these two parallel phase 2A trials that have really tried to understand the cytokine response against two different approaches for residual inflammatory risk for cardiovascular disease. We'll have the results of these trials early next year, but what we're trying to say is, can we take a genetic identified population that's specific for a specific pathway and pathology and have a targeted therapeutic for that pathway to prevent cardiovascular disease, and test that same approach with a more broad marker. So as many of this group knows, HSCRP is a robust marker of inflammatory risk that's been shown for many years to mark increased MACE events, but may not be as specific for this pathway. So we want to test both these approaches and then also have polygenic risk score post hoc comparisons. Beyond this, I think some of the applications can go can be even broader, sort of selection for enhanced event rates, for shorter, faster, earlier trials, and potentially expanding the patient population. So I think for example, for polygenic risk, the utility in sort of a high-risk primary prevention population really has appeal. I think a lot of the trials have focused on secondary event populations, but if you can really identify the patient population that has the same event rate as a secondary prevention population, that preventing someone's first heart attack is as valuable or more value than preventing someone's second heart attack. So I think there's a lot of potential future applications. So in summary, genotype-guided pharmacotherapy approaches hold promise. I think the translational medicine, these early clinical development programs really give us a flexibility to do more novel approaches. However, we don't have the benefits of some of the more clinical outcomes like heart attacks and strokes that you need longer, bigger trials for. Pros and cons of the different approaches need to be carefully weighed. These immense genetic data sets continue to grow, and I think provide us lots of opportunities to test treatment response and greater risk benefit with patients. And we really need well-designed, rigorous, prospective clinical trials to really demonstrate the clinical benefit and deploy these for patients. So thank you very much.
Thank you very much, Mike, for showing us these new opportunities, new developments in treating cardiovascular disease. So the talk is open for discussion. So I might get started. You showed that clinical risk has a great impact on the outcome of trials because we select our patients for a certain amount of clinical risk. And you also showed that there are parameters that give additional information like CHIP, like the polygenic risk score, or perhaps CRP. Isn't it at the end of the day the total expected risk that should guide our therapy? So a measure that combines the clinical risk measures and the additional risk that comes from these factors, rather than, having a CHIP-driven study or PRS-driven study or CRP-driven study, having a study that makes use of these parameters to really have a more precise information on the total risk and then do the trial based on the total risk.
Yeah, it's a very important consideration. I think there's two important points. First, to some extent, we are a victim of our own success, where event rates are getting lower and lower and lower, and it's getting harder and harder to run cardiovascular outcome trials that are short enough and small enough to be feasible. And so very much the overall risk matters in terms of the event rate per year. But I think you can't talk about increasing risk without talking about the expected response to therapy. And so ideally you have something that increases risk, but also increases the response to the therapy that you're giving. So if you increase risk, but those patients don't respond to your therapy, like we don't need any of these markers to have a very high risk patient population. You go into cardiogenic shock after an MI, the event rates are very high. You don't need any omics to test you that. But what you need these omics is to give you a high risk population that's going to get very, very high benefit. And so when you start mixing many different markers of risk, they may not respond to the therapy as well.
I don't believe that, but because you have showed examples that it's the opposite. The PRS increases risk, but it also increases the response to therapy. Not only canakinumab, but also statins, PCSK9 inhibitors. They all show a greater response to therapy if they have a high polygenic risk score. You showed the same for CHIP. So the risk increases exponentially with these additional factors, and if you do something to decrease the risk, you have a slide down on this exponential curve. And therefore the response to treatment will be bigger. That is at least my presumption.
Yeah, and I think that's an important point, whether we're talking about absolute risk reduction or relative risk reduction. So yes, if you push up the absolute event rate for the same relative risk, you'll have a greater absolute benefit, for sure, and that's very important for patients and populations. I think there are some examples where it's not as benefit. So let's take HSCRP. So for example, patients that benefit the most on CANTOS had lower on-treatment HSCRP, but they actually had lower baseline HSCRP. And so HSCRP may be actually identifying patients with an inflammatory response that doesn't respond as well to these therapies. So I think it can go in both ways.
I have actually two questions or comments. So I found it interesting in your introduction, you showed the picture where there is genome research going on and what are the resources. And I saw Central Europe, Germany. I couldn't see anything there. So DigiMed, the data which are generated, will they be added as a circle in the future on these pictures?
So I think that came from North American authors for that review. So they might have had a particular bias. I think the focus was specifically on large genomics data sets where you can actually recall patients. And some of those cohorts that they showed, it's not as easy as they make it sound to recall patients based on a genotype. But I think that's an important aspect of whether a genomics cohort can do that. And I would allow others to respond about DigiMed.
Well, I hope it will be the future. The second.
Yeah. So I was thinking we have heard about the NHS health system, about Namibia, and when I think about polygenic risk scores which are calculated worldwide, how much they consider the standard of care in the different situations in these risk calculations.
So I think that's important in terms of the magnitude of risk related to different variants and how that might be different in different environments and different standard of care. I've heard great comparisons where if you try to implement polygenic risk scores today for a therapy, it's like giving one ethnic group the most high-tech way to measure blood pressure, and then a different ethnic group, a blood pressure cuff from an old one. So I think there's a lot of work to be done, and that is one aspect in terms of the environment and standard of care.
Thank you very much for the exciting talk. And I think in addition to the information regarding the overall risk, that the scores could give us also more insight as to where our focus should be in terms of therapy. So for example, in patients that have CHIP, maybe the anti-inflammatory axis is more relevant than other axes, whereas in diabetics, maybe it's more a combination of anti-inflammatory. So do you see any perspective that on top of showing the overall risk for a patient, also that could more be instructing in terms of our major focus of therapy?
Yeah, I think you can tailor the development of polygenic risk scores for specific goals. So in general, often polygenic risk score for cardiovascular disease is just developed on overall event rates. But for example, if you want to develop therapies that are above and beyond standard risk factors, you can develop polygenic risk scores that are independent of LDL lowering and blood pressure lowering and LPA lowering or whatever. And so it's sort of giving you who's at high risk that's not addressed by current known pathways. So there's definitely opportunities there.
Okay, thank you very much for this great talk and the perspectives from Novartis. We continue with Professor Tobias Dreischulte, who will come from another perspective, looking at the effects of pharmacological treatment from the entire population, and we are looking forward to your insights.
Thank you very much, Professor Schunkert. The slides up here. Yeah, as Professor Schunkert has already said, this is a bit of a thematic shift now. So far, we've heard a lot about genomic data, imaging data, and especially in the context of developing new therapies in cardiology. I want to talk about mainly about claims data today, and how claims data can be used to optimize drug therapy more generally. and also, to make a case for why we might want to invest more resources into developing pharmacoepidemiology in Bavaria. Oh. Achso. Der Grüne, ne? Nee. Okay, we can also skip this slide, I suppose. Don't have anything in particular to disclose. Next one, yeah. Ah, yeah, okay. Okay, so yeah, just a brief overview. I'll just briefly talk about what is actually pharmacoepidemiology. I'll then also make an argument as to why I think that polypharmacy is a key challenge for drug therapy, but also healthcare more generally. How we can use real-world data and claims data in particular to address this challenge, and what the opportunities are for Bavaria in this context. So what is pharmacoepidemiology? It's usually described as a discipline that combines clinical pharmacology and epidemiological methods, and it deals with the utilization of medicines, so how are drugs used by prescribers and patients, but also looks at the effects that existing medicines have on patient outcomes. And it does so by using real-world data. The basis of this research is really in claims data, but increasingly it's being enhanced by other linked data sets from registries or electronic health records. And there are mainly three different fields within pharmacoepidemiology, three different types of studies. One is about identifying new risks of newly marketed drugs in particular, and in quantifying the effects, both risks and benefits of those medicines. It's about how drugs are utilized by patients and prescribers. And increasingly it's also about predicting the effects on safety and effectiveness endpoints. And as such, it's relevant for clinicians, obviously for clinical decision making, but also for regulatory decision making, for example, by the FDA or the BfArM in Germany, but also for health policies. So, for example, the Gemeinsamer Bundesausschuss, who decides which therapies are actually being funded. So a key challenge for drug therapy more globally is polypharmacy, and the WHO has actually reinforced this by a relatively recent report where they did a systematic review of studies that looked into reasons for hospital admissions, and found that about 1 in 20 emergency hospital admissions to hospital is drug-related, so due to the adverse effects of drugs. And in 2012, it was already estimated that in Germany, those admissions account for about 1 billion euros annually. The patients who are at greatest risk are older people with polypharmacy, which is usually defined as the use of 5 or more drugs simultaneously. And as you will all know, if you've got a myocardial infarction, then you end up already on 5 therapies. So it's not surprising that the prevalence of polypharmacy is increasing. And it's expected that in the year 2030, there will be about 10 million Germans aged 67 or older who get 5 or more drugs simultaneously. So polypharmacy is often inevitable, but what goes wrong, I mean, or what would be targets for improvement? I mean, one problem is that patients come to their doctors, often their GP, they have an acute problem, and for that acute problem there are specific guidelines, and those guidelines, they propose specific or recommend specific drug therapies. But if they have multiple problems, then one drug gets added to the other. And at some point, the benefits of combining these drugs do not outweigh the risk of harm. And therefore, the interaction of drugs with medical conditions, they lead to an increased risk of harm or medication errors. So rather than this linear process of prescribing one drug for each disease, we need to come to a point where we have feedback loops integrated into the system. So one of those is we need acute risk alerts. So a patient comes to the consultation, a new drug is added, and we need some kind of alert if there are interactions. But we also need more periodic review, more holistic review of all the medicines that a patient is taking to see whether over time the risk-benefit balance changes. And these ideas are not new, but we also need policies or incentives. We need tools and education to make sure that, that these are actually implemented and used. So, although these ideas are not very new, there are still ways, or there are still problems in actually making them work. And I would first like to focus on these acute risk alerts. You probably all know those systems that blink and give warnings when you try and prescribe a drug, that give you warnings about drug-drug interactions. But there are so many drug-drug interactions. Those systems are usually based on theoretical considerations, and they warn against even about theoretical risks. So with so many irrelevant alerts, there's then easily alert fatigue, and these warnings get to be ignored. So we need to know, when do we actually need to warn? What is the threshold at which we think that there is actually a relevant risk? But there's very limited data on which we can base the decision as to what we should warn against or not. Trials, when drugs get marketed at that point, we know a lot about this population here, so relatively young people with relatively low numbers of simultaneous drugs, but we know very little about this population here, older people on multiple drugs. And claims data or real-world data can help us to better quantify and characterize those risks. So just to give you an example, in geriatric patients were very much worried about fractures, falls and fractures. This group from the European Geriatric Society, they've sat together and they've looked at studies and identified a whole range of very commonly prescribed drugs which they consider fall risk increasing drugs, or FRIDs. So as you can see, if we had an older patient and it would generate a warning every time that a patient is on one of these drugs, we easily get to the problem of alert fatigue. So what we did was we conducted a study with a population-based data set from Scotland, where I worked for 10 years. And we looked at various drugs, but also on combination of these drugs. And we found that obviously there are relevant risks with these drugs, but especially in those aged 75 years or older. And especially in those who get more than one of these drugs. So if we say, for example, with this data, we could, for example, say, okay, let's generate a warning if somebody gets 3 of these drugs together, but perhaps, you know, only taking one is not such a big problem. So the second issue is with these medication reviews. So a lot of guidelines recommend that a holistic medication review should be done in every patient 65 years or older who takes 5 or more drugs simultaneously. But as I've already said, you know, that part of the population is growing, and if we do some calculations here, we assume that a medication review takes about an hour and costs about 150 euros per review. We can calculate, let's say GPs are doing these reviews, they would have to actually work 5 additional hours per week to get that done, and the insurance companies would have to pay 1.5 billion euros to do this. So clearly there's a case for better targeting of those potentially effective interventions. But there's very limited research so far on who we should target. So we're still working with thresholds of numbers of drugs and ages, but we don't really know anything about the specific risk of individual patients. So there's only one paper that I found on this, and they looked at drug-related hospital admissions generally, and they found very poor prediction. So we therefore are currently doing some work on developing risk models for specific adverse events, and we've done some preparatory work on this to identify or prioritize events that are particularly relevant to medication safety in older people. So let's assume that we've got you know, better risk alert systems, better prediction rules. We need to also ensure that the knowledge gets actually into practice. And how can we use data to help the implementation? Just want to give you an example of a study that we've done in Scotland, where we recruited 40 general practices in this area here of Scotland, and we implemented in those practices an IT tool that could identify patients who were at increased risk of GI bleeding, acute kidney injury, or heart failure from high-risk use of non-steroidal anti-inflammatory drugs and antiplatelets. We also gave them education, and we gave them, we offered £15 per review when they looked at these patients and optimized treatment. And what we found was that there was a substantial decrease in targeted high-risk prescribing from this intervention. It influenced both stopping drugs that patients no longer needed, but it also reduced high-risk prescribing, future high-risk prescribing. And we could also demonstrate that these changes in prescribing habits were associated with reduced incidences of GI ulcer or bleeding hospitalizations and heart failure hospitalizations. So these, I hope I've convinced you that real-world data-based research can plays a vital role in or can play a vital role in preventing drug-related harm and hospitalizations, but there are some challenges to that in Germany so far. I mean, I've shown you data. We're mainly working just now with the Scottish database. It's getting better in Germany, but there are still some bureaucratic hurdles in using this claims data more efficiently. And I think we have an opportunity here to go forward in Bavaria. I mean, we all know that there's new legislation at a federal level with this Gesundheitsdatennutzungsgesetz. They're establishing a center, a data center at the BfArM, that holds claims data for 70 million insured patients from all statutory health insurance. But it's likely that access to this data will continue to be limited, and the progress in establishing the center is actually very slow. There's also some plans for data linkage with registries and so on, but all of that is going very slow. So I think there is we have an opportunity here. Jens Wiele has already highlighted this with the Bavarian Center for Health Research that is on the horizon at least. But the main point I want to make is that to enable this kind of research, we really not only need genomics data, imaging data, but we need to integrate claims data into this health cloud, to enable this kind of research. And we also need to build some more capacity in doing this kind of pharmacoepidemiological research, and which does have its challenges, and my colleague Niels Krüger will talk about that in more detail. But I just want to highlight that we are running courses on pharmacoepidemiological methods in collaboration with Harvard University, and whoever is interested, the next course is in May of next year. So thank you very much.
Thank you for introducing this really important field of research to us. Any questions? So I might get started. I mean, you said that you want to use claims data and particularly look at the effects of polypharmacy, but how are events in claims data identifiable if they are driven by polypharmacy? I mean, if there is like a hip fracture, which may indeed be a consequence of too many antihypertensives or whatever. I mean, how can you identify this as a consequence of wrong or too much therapy?
Well, you're alluding to the causal relationship between drug treatment. That's obviously at the moment not possible. I mean, we can get hints towards that. Let's say if we have a fracture, and the person who had fracture was exposed to 3 or more fall risk increasing drugs in the previous 3 months. I mean, that would be one way of getting closer to fractures where drug therapy at least played a role. But it's also true that attributing a fracture to a particular cause is difficult in any case. It's also very difficult in clinical practice. So it's, those are multifactorial problems. But if we can identify somebody who has a high risk of fractures, who is then also on multiple treatments that increase that risk of fracture, I mean, that is the point where we could intervene, or where we should intervene in optimizing treatment.
I don't see for the moment, so thank you very much, and good luck with you.